Yeah, dear Chairman, thank you for the invitation again to speak about a topic that I very like, the conduction system pacing. It's not shown in the program. There is only shown where it's the pointer here? No, there's no. The new ASC era consensus paper. And this is endorsed by the Asia Pacific Heart Rhythm Society, the Canadian Heart Rhythm Society, the Heart Rhythm Society of the United States, and the Latin American Heart Rhythm Society. So I think it's truly a global effort. How it goes? Representatives from all around the world participated, including not only CSP specialists, but also heart failure experts. Why was this consensus document necessary? The 2021 ESC guidelines adopt a very conservative stance on conduction system pacing. Formal recommendations were limited to his bundle pacing, while no recommendation was given for left bundle branch pacing due to insufficient evidence at this time. Overall, the guidance remained restrictive. His bundle pacing received, it's don't work. His bundle pacing received a class 2-1 recommendation only in cases where coronary sinus lead implantation for CRT was unsuccessful. In other scenarios requiring antibradycardia pacing, CSP was assigned only a class 2B recommendation. At the ACC Congress in Hue last year, I asked the audience, what is the future of ventricular pacing? If you ask leading electrophysiologists, as in this ERA survey of 184 physicians from 31 European countries, primarily from university hospitals, only 15% still consider conventional right ventricular pacing appropriate for bradyarrhythmias. For CRT indication, expected use of traditional biventricular pacing also dropped to just 28%. The clear winner is conduction system pacing, particularly left bundle branch area pacing, which is expected to dominate over conventional RV and biventricular pacing in the future. This represents a fundamental shift in pacing therapy. The consensus document responds to the creating adaptation of CSP, acknowledging that large randomized studies will not be available for several years. To avoid conflict with existing ESC guidelines, the consensus introduced a new iconography. This system classifies what can be recommended, what is reasonable to perform, what should be avoided, and very importantly, areas of uncertainty where no recommendation can be made. A second symptom system was created to reflect quality of evidence. As many consensus papers, the document is grounded on expert opinion. Every statement was voted on and required more than 90 or 70% agreement. Statements with less than 70% consensus were not accepted. Let us begin with the AV block patients. ECG analysis makes the rationale clear. Conduction system pacing preserves physiological activation. The QRS complexes are narrow, whereas RV apical pacing induce wide LBB-like complexes. This is clinically relevant because pacemaker-induced cardiomyopathy develops in up to 20% of patients with frequent RV pacing. In Kerschel's study, the left ventricular ejection fraction decreases from 62% to 36% of a period of 3.3 years. Patients' outcomes show that they are far better with his bundle pacing. Abderrahman et al. Performed one of the largest case control studies of his bundle pacing versus RV pacing. Two sister hospitals were analyzed, one using predominantly RV pacing, the other his bundle pacing. His bundle pacing is the light blue line, showed a significantly better outcome for death, heart failure hospitalization, and CRT upgrade. Patients with more than 20% pacing burden delivered the greatest benefit. The next case shows a patient with total AV block and an escape rhythm with narrow QRS complex. Implantation in the his bundle position was unsuccessful, and we opted for a left bundle branch stimulation. The stimulation shows a selective LBB pacing with a narrow QRS complex and a change in QRS morphology. The X-ray shows the final position of the electrodes. The consensus paper recommends a CSP implantation as a rescue strategy of coronary sinus lead implantation fails in patients with ventricular block who require biventricular pacing. On the other hand, right ventricular pacing in case of a V block, an ejection fraction below 40% and frequent pacing burden is discouraged. This largely corresponds to previous guideline recommendation. Therefore, the recommendations are paramount in determining what is appropriate. Implantation of a CSP may be suitable for patients with an ejection fraction above 40% and an expected pacing burden more than 20%. Similarly, CSP may be considered as an alternative to biventricular pacing in patients with low ejection fraction and a high pacing burden. Even with an expected pacing burden below 20%, CSP may be considered with an algorithm minimizing ventricular pacing. And finally, it may be appropriate to choose CSP over biventricular pacing as a primary strategy in selected patients where a simpler pacemaker device may be preferable. Let's move on to the next group, patients undergoing a V-node ablation. The ECG shown demonstrates a VVI ICD patient who underwent a V-node ablation due to uncontrolled or limited left ventricular ejection fraction, uncontrolled tachycardias in atrial fibrillation. During VVI stimulation, wide ventricular complexes exist with the risk of further deterioration of the limited ejection fraction. After upgrading to his bundle pacing, however, narrow QRS complexes, So, narrow QRS complexes remain. It is understandable that the majority of electrophysiologists would prefer conduction system pacing after a V-node ablation. Su could demonstrate a long-term follow-up of more than 3 years that in patient after V-node ablation, his bundle stimulation does not worsen the ejection fraction. In patients with a reduced ejection fraction, there was a significant improvement from 30% to 54%, while in patients with a normal ejection fraction, it does also increases significantly. In a retrospective observational study, Rahman found the primary combined endpoint of time to death or heart failure hospitalization significantly reduced in conduction system pacing compared to conventional pacing. Let us now turn to the ESC era consensus statement. If the ejection fraction is below 40%, biventricular pacing is the first choice, but conduction pacing may be also indicated. Similarly, conduction stimulation may be indicated in cases of an ejection fraction between 40 and 50% or above 50%. In his bundle stimulation, the implantation of a ventricular backup electrode is recommended. Alternatively, left bundle branch pacing can be performed without a backup electrode. LOT CRT and if coronary sinus implantation fails, you will see examples later on. Is conduction system pacing also an alternative to biventricular pacing? In the largest observational study with 1,700 patients from 15 international centers, the primary endpoint of death or heart failure hospitalization was highly significantly in favor of left bundle branch pacing. This was solely driven by a significant lower hospitalization rate. Mortality was very low in both groups at 3 to 5% per year, but these excellent results still need to be verified in randomized head-to-head comparisons. A current meta-analysis compared biventricular pacing with conduction system pacing in patients with heart failure and reduced ejection fraction. The analysis included 7 randomized studies with a total of 400 patients. There was a significant reduction in QRS duration and symptoms with conduction system pacing and an improvement of left ventricular ejection fraction. There was no difference between the groups in terms of left ventricular end-systolic volume, an established prognostic factor, and the threshold for leading capture. If you looked at the hard endpoints, hospitalization for heart failure and mortality, 5 randomized trials with 155 patients remain. There was no difference between biventricular CRT and CSP for either outcome. Let's return to the consensus statement. In patients with left bundle branch block and a left ventricular ejection fraction below or equal 35%, biventricular pacing is initially recommended, and CSP may be appropriate as an alternative to biventricular pacing. In patients with left bundle branch block and a moderate reduced left ventricular ejection fraction, it is unclear whether a biventricular system or CSP should be used. For and that is very important, for the patient with non-left bundle branch block with reduced ejection fraction, a biventricular system is primarily recommended. And the efficiency of CSP in this group, in these patients, is uncertain, particularly for patients with intraventricular conduction delay. For non-left bundle branch block with moderate reduced left ventricular ejection fraction, there is uncertainty regarding both techniques. There are limitations in our method. Biventricular pacing is recommended in patient MESA-induced cardiomyopathy. CSP can be considered in these cases, and if there is no response to biventricular pacing. If a wide and non-physiological paced QRS complex persists, switching to HOT or LOT CRT is possible. I will show you an example. And in case of failed coronary sinus lead implantation, it is recommended to perform conduction system pacing. Finally, I will present the case we operated last year in Hanoi. In the next case report, I show you an 82-year-old male with heart failure New York class 3, ejection fraction of 40%, and an ischemic cardiomyopathy, who had a VVI ICD implanted after surviving sudden cardiac death. He has now developed an AV block 3 with an escape rhythm with a QAS duration of 176 milliseconds. Right ventricular pacing via the ICD widening the QAS complex to 208 milliseconds. Under this constellation, complete cardiac decompensation would be very likely. Therefore, we decided to perform left bundle branch pacing on the patient with limited success. The intrinsic QAS complex was narrower with 138 milliseconds, but the entire QAS duration was long. We therefore decided to implant a CS electrode. The value under LV pacing were disappointing with 174 milliseconds. But the combination of left bundle branch pacing and CS pacing, so-called LOT-CRT, produced a satisfactory result with a QAS width of less than 120 milliseconds. For patients with severe ventricular conduction disorders, especially in patients with left ventricular conduction delays, this combination appears to be the ideal method to achieve maximum resynchronization. In the last case, we see Wolfgang Feske at work. He demonstrates an asynchronous left ventricular contraction. The patient had unsuccessfully undergone implantation of a biventricular system. The CS electrode was dislodged, and given the venous morphology, CSP was chosen. On the right, you can see the joint operation team. The initial findings are shown with a QAS duration of 172 milliseconds. The guide catheter of the LBB electrode is inserted in a right angle to the septum. After deep insertion of the electrode, QAS complex narrows to 124 milliseconds, and you see the surface ECG. It shows a normal conduction with narrow QAS complexes. This will normalize ventricular function and significantly improve the patient prognosis. Thank you for your attention.